we've now got time for a chat. We've got 15 minutes to talk to the speakers that we've heard from this afternoon, and both on the patient and carer race equality framework and the brilliant work being done in South East London on obesity and diabetes. And what struck me was that in both cases there's a real emphasis on tackling health inequalities and particularly relating to diversity, our diverse communities in South East London. And it's brilliant to hear that there's such impactful work going on here. I suppose my interest is how do we translate, how do we spread that best practice nationally and indeed internationally? There's clearly so much to learn from the work on PCREF, but also the work you're doing in diabetes and obesity. So, I mean, Jacqui, give me your thoughts on how we get this happening across the country.
So I often think of spread as being something which is like bi-directional learning. So it's not a one-way thing. It's actually you're learning together.
Sure.
So that's how I think of spread. It's like a shared learning experience and cultivating those opportunities where that can take place. So the PCREF, the acronym for the Patient and Care Race Equality Framework, operates across 4 pilot sites in England currently, of which South London and Maudsley is one of them. And we also have early adopter sites. And some of those early adopter sites are mental health trust areas, as well as...
Beyond the 4 pilots?
Beyond the 4 pilots, yeah. There's early adopter sites, additional mental health trusts, but also additionally ICS, ICB areas.
So we've got the integrated care system.
Yeah, the integrated care system. So that actually you've got PCREF working group at a regional level.
So it's creeping off all over the place.
In order to spread it much more widely, because people appreciate that this level of systematic co-productive work where actually you're working really closely with communities and partnerships and collaborations to actually make the service improvements across all care pathways, be that inpatient care, be that children and young people services, be that perinatal mental health services, be that psychological services, will really help us to address the inequities that the data constantly for decades says is that there's a differential experience.
And it's a bit of a new way of working for the NHS.
I think so. I think it's building on some of the work, the co-production work that happens in pockets, but we're getting much more robust and systematic about doing it.
And vital in building trust.
Yeah, of course, and having a level of integrity. Yeah. Because what we want to do is build trust so that people engage with services rather than being terrified of mental health services. And they can do that if they've helped to co-create what those services need to look like.
Brilliant. I knew you'd give a great answer there. So let's just hear about the great work on diabetes and the footwork. I mean, I was amazed to hear about the reduction in amputations, for example, but how do we get this spread across the country and indeed internationally?
Norman, it's about taking what we have done with the KHP partnership is easily transferable. And like Jacqui said, it's about getting the people and systems external to our region understand that it A, can be done, and B, providing support to these areas. For example, previously all the care was based through the 2 big hospitals, Thomas's and King's. What we have done through the network is transfer some of those skills to local providers and support staff locally. Patients,
and I guess you're building up the competence,
will realise they're part of one big team and they're not being seen by 2 separate teams, and that makes the difference. It builds a relationship, it builds confidence, and the delivery teams locally understand that they can manage very complex individuals, so it makes it more seamless.
So fewer people end up having to go to a remote hospital.
Exactly, and it reduces the dependency and equity at the higher centres.
Steve, did you want to add something?
No, I think it's said very well, but it is really about the partnership working. It's not KHP going in and taking over delivering something. It's about partnership working with the local communities and with the local hospital providers. So the whole system has to come together.
Yeah, so the partnership working actually aids you in doing your job effectively.
That's exactly right.
Yeah. Let's go to Jill and get another question from the audience.
Thanks, Norman. So lots of support coming through for all of the presentations in this last session, particularly for Zoe and Jacqui's work, and a question for them. Wonderful to see practical tools for how to be anti-racist. Absolutely welcome that. How does PCREF support other marginalised groups, not just black citizens that you spoke about in your presentation? I think your work goes much further, doesn't it?
It certainly does.
You want to talk about
Absolutely.
that?
But
Zoe.
and a chance just to clarify that obviously I only had 5 minutes to do my presentation. So what SLAM did was look at its data.
SLAM, we should say, South London and Maudsley.
What South London and Maudsley did was look at its data, and it came up, straight into our face, that if you were black African, black Caribbean, black mixed or black other, you were likely to have poorer access, experience and outcomes. So that meant that we
And they're more likely to be detained.
More likely to be detained, more likely to be in seclusion, all the things that you don't want to happen. Yeah. And so we took a brave decision to focus on that community in terms of phase 1 of the PCREF. This is the first iteration. Yeah. And our real intention is to shift the dial for black people, as described, over the next 2 years. And then we will start to look at the next level of people who are discriminated against and focus our work then. So in that way, we will eventually, cover the whole.
Makes absolute sense to focus on one area.
Can I just further add to that? So I think that the point is that it's all marginalised communities that have a differential experience to the white majority. So depending on where your geography is, what your demographics are like, you will look at the data, and it's important to get closer to good quality data across all equality protected characteristics, gender, ethnicity, disability, the intersectionality therein. And you are now responding to your population's needs and working with those more marginalised communities that are experiencing a differential set of outcomes.
Yeah, brilliant. Jill.
Just lots of other questions coming in. This one for diabetes and obesity. So a number of partnerships and other system-wide collaborations on the call today, and they're thoughtful about what is it about your experience in diabetes and obesity that they can learn from. What would you best recommend to them about this approach to system-wide working?
Who's going to... Steve.
So I think everybody said it really. You need the right information, and that comes from data. And the data should give us information that tells us things like you just quoted, and to know where the problems are. And then you need to develop a lot of trust and confidence. For good reasons, a lot of data is used as a performance management, and that makes people very nervous about sharing data. You want to create a trust and a belief that you're all working together, primary care, secondary care, community care, whatever, looking at the data giving us information to define the problem that we're all going to sit down and try and fix, not to compare X with Y or Z with B in the way that you just illustrated. So I think that's the crucial thing. And then you get all the right people focused on the same problem. You get all the right minds focused on trying to fix a common goal, a common issue. And I think that's the crucial thing to building up the partnerships, if that makes sense. And
it takes time, I guess.
It takes time. So we've been working on this for several years. And one thing I was proud about, we won an award for partnership working with our community provider. The reason I was proud of that is because if you go back 5 years, there was major warfare between the providers about who was taking over, who was going to do it. And the truth is that the problem defines itself and brings you together, if that makes sense, if you will focus on that. So that would be the key message. It takes time, it takes building up relationships, and that's what networks are crucial for. But always be guided, I think, by information from the data and give people confidence that that's what you're going to use it for, not to say you are better or you are worse or anything like that.
Al, have you... is this all written up? Is there some sort of toolkit that others can use that can be applied elsewhere?
Yeah, thank you. It's coming. So we're just in the middle of developing that now.
Brilliant.
I would say that we need to have courage as well to spend the money on co-design methodology. Yeah. It's not the cheapest thing to do if you do it properly, but you can see from the presentation that I gave that it reaps dividends. So to bring everyone together, to hear everyone's voice. For me, one of the most remarkable things that was said in that the co-design workshops was how much mistrust there was of the NHS and local authorities. And they were very clear, the community representatives and community leaders, that a big shiny organisation like King's Health Partners should not come in and take over and deliver this intervention. So we very much saw it as our role to work in close partnership with grassroots organisations who, let's face it, are not set up to bid for funding and to measure outcomes in the way that, for example, the NHS is. So we work very closely, and I'm pleased to say that the grassroots organisations that we partner with are delivering the majority of the stuff. And then behind the scenes, it's our responsibility to.
So you learned
admin.
that was the best way of doing it through doing the partnership working, I guess.
Absolutely.
Which
yeah.
is fantastic.
Yeah.
And I guess, I mean, I mentioned earlier that you've had a big impact on the well-being, the happiness of many people. But I guess also there's a significant potential saving for the NHS, which is, we all know, is under enormous financial stress. But it means that we can use the money for healthcare for others if we can achieve those savings.
That's a great point. Yeah, so we are seeing outcomes in terms of reduction in waste and weight, blood pressure, and so on. So absolutely.
But also, I mean, if you're stopping the deterioration of health with something like diabetes, there must be enormous savings in healthcare for those complex needs later on, I guess.
Yeah.
Yeah. Jill.
Last couple of questions, Norman. So what's the opportunity through the partnership for working with local restaurants, takeaways to reduce obesity, particularly in children and young people? And what is some of the data that we might have on that? I wondered if Al wanted to come in on that one.
Thank you, Jo. Well, that's really hard. I mean, it's a very political question, let's face it. In Lewisham, there are 48 chicken shops for every secondary school. And it comes down to deprivation. I mean, all of us are aware, if you...
And this is fried chicken, so...
Yeah, and chips, yeah.
Yeah.
But, what choices do we have? If you're on a restricted income, 6 sausage rolls cost the same as a head of broccoli. If you've got hungry children to feed, what are you going to go for?
Yeah.
And that's the reality we live in. I think in terms of our role, yes, we can educate, we can support, we can provide the information on how to live a healthy life on a restricted income, but ultimately I think it's for the politicians out there to help us on this.
Yeah, my old place of work, they need to get on with it. Jill.
Last question, it's a tough one as well, and I think it really, Norman, it's for you and Jacqui. So has the impact of the pandemic built trust with our local communities in NHS and public services, or has it reduced it, and how do we move forward? That is a tough final question for today.
Well, I would just say one thing first, and then I'm fascinated to hear from you, Jacqui. I mean, another programme which is all about partnership that we've embarked on is, we call it South London Listens, but this is a collaboration. It's a sort of public mental health approach, so intervening early, supporting communities, recognising that there's a psychological fallout from the pandemic. We had 450 people in a theatre in South East London a couple of weeks ago. And this is all about communities collaborating with both mental health trusts and local authorities. So I think this has to be the new way of working. And I'm sure there will be areas where the distress that many people went through, particularly in the black community, who suffered more through the COVID pandemic, will have had an impact on trust in a negative way. But I think the way we've tried to respond is what we should be doing. But over to you, Jacqui, for the last comment. We've got a minute left.
I think it's different for different groups. And I think that we have to be honest about those differences, and therefore we have different responses for different groups because of their differential experience. I mean, hundreds of years of oppression and discrimination and disadvantage in every aspect of your liberty is something that creates a whole different health and well-being, mental health, physical health kind of experience than, say, some of your, as I speak as a black woman, my white counterparts. It's a whole different liberty that it's not one size fits all. And what was exposed really in the pandemic was, I lost one of my siblings in the pandemic. and that's the second siblings that I've lost as somebody journeying with mental health challenges. Systems failed, so that we experience a lot of system failure. So one size fit all kind of approach won't address. But I think being creative and dynamic and being honest about the differential experience, we can actually make progress, and that can be great for all of us.
Brilliant. Fantastic panel. Thanks to all of you.